Curious, analytical, a slow, quiet, yet deeply destructive process known as organizational drift degrades the integrity of mental health care. This drift pulls modern facilities backward, recreating the environments of the custodial era. These historical precedents were designed to passively house patients, prioritizing stability over active rehabilitation. The human cost of this passive care is evident in the treatment of schizophrenia. While standard antipsychotic medications effectively suppress hallucinations by targeting dopamine receptors, they do not address the severe cognitive deficits associated with the disorder. Impairments to working memory, the system the brain uses to hold and process information, are often left entirely untreated in custodial environments. These passive environments often persist because of how they are audited. The primary administrative tool for these evaluations is the standard 5-point scale. On a 1 to 5 scale, a score of 3 represents a meets expectations middle ground. In practice, assessors frequently use this safe 3 to mask subpar performance and avoid the difficult confrontational conversations required to drive administrative change. When a system permits the ambiguity of that middle score, it allows the facility to function as a static custodial trap. Patients survive inside, but the lack of clear accountability prevents true recovery. Breaking that cycle requires an unambiguous scoring system. The Social Interest Consulting Group's Universal Core Assessment accomplishes this using a 4-point forced choice scale. This follows a core communometric principle, where measurement is used specifically to dictate clinical action. By removing the neutral middle ground, any rating of 1 or 2 automatically triggers a mandatory corrective action protocol. The diagnostic framework consists of 60 specific evaluation items. These are distributed across the 8 operational domains shown here, from staffing and training to quality assurance and outcomes. Modern facilities must also navigate overlapping layers of oversight, including international CARF standards and Illinois-specific Title 77 Part 380 regulations. The assessment manages this complexity through the Snap-on SMHRF regulatory module. This adds 66 facility-specific items directly to the core framework, triangulating compliance across different regulatory codes to ensure granular coverage. This forced choice architecture eliminates administrative hiding spots. It transforms the regulatory audit into an unavoidable mandate for structural improvement. Once the scale triggers a corrective action, consultants deploy a root cause analysis, or RCA, toolkit. This is a structured process used to uncover the underlying reasons for a system failure. The goal of RCA is to shift focus away from individual human error. Instead, it identifies the correctable structural failures within the facility's workflows. The 5 whys technique traces simple, linear problems to their origin, asking why repeatedly to bypass surface symptoms. For complex breakdowns, the Ishikawa diagram maps causes across 7 categories, like man, machine, and method, identifying all contributing factors rather than assigning blame. The ultimate diagnostic is first principles thinking. This involves stripping away inherited assumptions to rebuild workflows based only on foundational truths. Utilizing RCA and first principles ensures that when a failure is detected, the facility repairs the actual machine and addresses the true system failures. Once facility operations are optimized, clinical teams can focus on patient-level rehabilitation. A stable, engineered environment provides the necessary foundation for high-precision clinical interventions. One such intervention is computerized cognitive training, or CCT, which is designed to target the cognitive deficits often left unaddressed by medication. CCT software employs structured exercises that automatically adapt task difficulty based on real-time patient performance. This provides the patient with personalized training and immediate feedback. This data from a double-blind trial shows the result of a 30-session CCT program. Compared to the control group, the intervention group showed measurable improvements in spatial working memory and a reduction in overall stress levels. The intervention also secured a system usability scale score of 83.51. This high usability rating, paired with a 92.7% adherence rate among study participants, indicates that well-designed cognitive tools can foster strong patient engagement. CCT represents the ultimate output of a functioning system. It is an active intervention that repairs neural pathways to restore independence. This entire operational framework is grounded in the principles of Adlerian psychology, pioneered by Dr. Alfred Adler. Adler's core concept is social interest, the belief that psychological health is defined by an individual's capacity to contribute to the welfare of others. This philosophy transforms the purpose of the facility's metrics. Basic regulatory compliance is merely the baseline, allowing resident voice and community integration to become the primary indicators of success. By eliminating the SAFE 3, enforcing first principles, and deploying precise cognitive training, a facility transforms from a static holding cell into an active rehabilitative engine designed to return individuals to functional independence.